السلام عليكم ورحمة الله وبركاته. بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا محمد وعلى آله وصحبه الصلاة والتسليم. My name is Dr. Asim. I'm gonna continue where Dr. Ranim finished. I'm gonna talk to you about diabetes education and management, specifically about hyperinsulinism and spontaneous hypoglycemia. Definition and background. Hyperinsulinism consists of insulin levels above 3 micro per milliliter when glucose levels are below 50 milligram per deciliter. Treatment depends on the cause and the severity of the hyperinsulinism. Congenital hyperinsulinism is a familial hyperinsulinism with profound hypoglycemia because of excessive insulin secretion. Congenital hyperinsulinism can lead to developmental delay, mental retardation, or death if untreated. Congenital hyperinsulinism occurs at an approximate frequency of 1 to 25,000 to 1 to 50,000 live births. New procedures spare healthy cells in the pancreas while allowing surgeons to remove abnormal tissue. Spontaneous hypoglycemia is an underlying symptom of some other disease beside diabetes. Fasting and reactive hypoglycemias fall into the category of spontaneous forms. Fasting hypoglycemia, the body is not able to maintain adequate levels of sugar in the blood after a period without eating food. People with islet cell tumors, viral hepatitis, cirrhosis or liver cancer, children with carbohydrate metabolic disorders like hereditary fructose intolerance, galactosemia, leucine sensitivity can cause this type of hypoglycemia. Reactive hypoglycemia describes recurrent episode of hypoglycemia occurring 2 to 4 hours after a high carbohydrate or glucose load. Symptoms include weakness and agitation 2 to 4 hours after meals, nervousness, mental confusion. Etiology or understanding the cause of hypoglycemia. Elementary hypoglycemia, dumping syndrome following gastric surgery. And the other cause is hypothyroidism or other hormonal disorders, H. pylori-induced gastritis, ocular diabetes with unexaggerated hyperglycemia during a glucose tolerance test. Diet remains the main treatment, although alpha-glycoside inhibitors and some other drugs may be helpful. Brain glycogen supports energy metabolism when glucose supply from the blood is inadequate and its level rebound to levels higher than normal after a single episode of moderate hypoglycemia. Glutamate serves important intracellular signaling functions. Glutamate dehydrogenase catalyzes the oxidative deamination of glutamate to alpha ketoglutarate in brain, liver, kidney, and the pancreatic islet. Interventions. Reduce intake of concentrated carbohydrate to a level that doesn't overstimulate the pancreas to secrete inappropriately large amount of insulin, which may cause blood sugar to drop. Limit total intake of carbohydrate to 130 grams to reduce the severity of symptoms. If required, ensure that patient loses weight gradually. Reduce counter-regulatory hormone responses to excessive insulin. Exercise regularly and maintain constancy in meal time and daily routine. Food and nutrition. Diet should include frequent small meals about every 3 hours. Eat a variety of food, including meat, poultry, fish, or non-meat sources of protein, whole grain fruits, and vegetables, dairy products. Choose high fiber foods and food with a moderate to low glycemic load. Avoid white rice, potatoes, corn. Avoid or limit food high in sugar, especially on an empty stomach. This includes sweetened beverage and dried fruits. Avoid caffeine. Maintain protein intake. Fat furnishes the reminder of calories. The traditional high protein, low carbohydrate diet is not evidence-based. For the GLUD1 genetic form of high insulinemia, a low leucine diet and use of diazepam may be needed. Most of the other genetic forms will require surgery or just drug use. Common drugs used and potential side effects. Diazoxide is needed for the GLUT1 forms of high insulinemia. Diazoxide is believed to inhibit insulin secretion through opening of cat channels. Octreotide, somatostatin analogs, or continuous dextrose is often used, but in cat pie, drug therapy fails and pancreatectomy is required. Chemotherapy, for example, streptozotocin and fluorouracil may be used for insulinomas. Monitor GI side effects and nephrotoxicity. Alpha glucosides inhibitors may be where diabetes is identified. Monitor all medications for their potential hypoglycemic effects. Herbs and supplements. Products such as hemocellulose and pectin may help in dumping syndrome. Herbs and potential supplements shouldn't be used without discussing with physician. Nutrition education, counseling, care management. Ensure that patient keeps snacks available such as cheese and crackers. More frequent feeding are needed. For example, every 3 hours, you have snacks Don't wait for the main meal, so you will not have hypoglycemia. Avoid skipping meals. Eat it on time. Avoid any one meal that is unbalanced or especially high in carbohydrate. Control caffeine intake and use of other stimulants which may aggravate condition. Patient education, foodborne illness. If home tube feeding is needed, teach appropriate sanitation and food handling procedures. Metabolic syndrome. Definition and background of the metabolic syndrome. The metabolic syndrome, like insulin resistance syndrome or syndrome X, has stimulants clustering of low level of HDL cholesterol, hyperglycemia, high waist circumference, and hypertension and elevated triglyceride. Any three of the following 5 criteria constitute diagnosis. Elevated waist circumference 40 or 102 centimeter in men, 35 or 88 centimeter in women. Elevated triglyceride 150 milligram per deciliter, or drug treatment for elevated triglyceride. Reduced HDL cholesterol 40 milligram per deciliter in men and 50 milligram per deciliter in women, or drug treatment for low HDL cholesterol level. Elevated blood pressure 130 systolic or 85 diastolic. The patient used drugs to treat his hypertension. Elevated fasting glucose 100 milligram per deciliter, or he used drugs to treat his elevated glucose. It's associated with cardiovascular disease and often leads to type 2 diabetes. This condition affects some young people, but usually affect person aged 55 years and older. More than 64 million Americans have it. Roughly 1 in 4 adults and 40% of adults aged 40 years and older. Increased birth weight, excessive energy intake, physical inactivity, obesity, smoking, inflammation, and hypertension contribute to it. Individuals who are obese and insulin resistant are particularly prone to this syndrome. An apple-shaped figures, high waist circumference, is riskier because fat cells located in the abdomen release fat into the blood more easily than fat cells found elsewhere. Serum adiponectin levels are associated with the insulin sensitivity. They are decreased in type 2 diabetes and obesity. Genetic and environmental factors contribute to risk. The initial insult in adipose inflammation and insulin resistance is perpetuated through chemokine secretion adipose retention of macrophages and elaboration of pro-inflammatory adipocytokinase. In women, depressive symptoms are associated with it, especially with elevated afternoon and evening cortisol. Clearly, more research is needed. The management should focus on lifestyle modification, especially reduced caloric intake and increased physical activity. Phytochemicals, antioxidant foods, species such as turmeric, cumin, and cinnamons have anti-inflammatory effects. Intake of whole milk, yogurt, calcium, and magnesium protect against syndromes where intake of cheese, low-fat milk, and phosphorus don't. Reduce the inflammatory state and insulin resistance caused by excessive adipose tissue, improve body weight, lessen abdominal obesity in particular. A realistic goal for weight reduction should be 7 to 10% over 6 to 12 months. Promote physical activity. Recommendation should include practical, regular, and moderate regimens of exercise with a daily minimum of 30 to 60 minutes and equal balance between aerobic and strength training. Achieve and maintain cholesterol, blood glucose, and blood pressure at level indicated by the American Heart Association as follows. For atherogenic dyslipidemia, for elevated LDL cholesterol, give priority to reduction of LDL cholesterol over other lipid parameters. Achieve LDL cholesterol goals based on patient's risk category. صوت واضح. LDL cholesterol goals for different risk categories are high risk, 670 to 100 milligram per deciliter, moderately high risk, say 100 to 130 milligram per deciliter, moderate risk, 130 milligram per deciliter, and the lower risk, 160 milligram deciliter is acceptable. If triglyceride is 200 milligram per deciliter, then goal for non-HDL cholesterol for each risk category is 30 milligram per deciliter, higher than for LDL cholesterol. If triglyceride 200 milligram deciliter after achieving LDL cholesterol goal, consider additional therapies to attain non-HDL cholesterol goal. If HDL cholesterol is 40 milligram per deciliter in men or 50 milligram per deciliter in women, raise HDL cholesterol to extent possible with standard therapies for atherogenic dyslipidemia, either by lifestyle therapy and can be intensified, or drug therapy can be used for raising HDL cholesterol level, depending on patient's risk category. For elevated blood pressure, reduce blood pressure to at least achieve blood pressure of 140 over 90 or 130 over 80 if diabetes is present. Reduce blood pressure further to extent possible through lifestyle changes. For blood pressure 120 over 80, initiate or maintain lifestyle modification through weight control, increased physical activity, sodium reduction, and emphasize on increased consumption of fresh fruit, vegetables, and low-fat dairy products in all patients with syndrome X. For blood pressure, 140 over 90 or 130 over 80 if diabetes is present, add blood pressure medication as needed to achieve goal blood pressure or ideal blood pressure. For elevated glucose, encourage weight reduction and increase the physical activity. In diabetes, for hemoglobin A1C at or above 7, lifestyle therapy and pharmacotherapy, if necessary, should be used. Modify other risk factors and behaviors, for example, abdominal obesity, physical inactivity, elevated blood pressure, or lipid abnormality. For prothrombotic stats, reduce thrombotic and fibrinolytic risk factors. Low dose of aspirin therapy or prophylaxis is recommended. For pro-inflammatory status, there are no specific therapy beyond lifestyle changes. The antioxidant and omega-3 fatty acid may be helpful. Food and nutrition. The general recommendations include low intake of saturated fat, trans fats, and cholesterol. Increased use of omega-3 intake, especially extra virgin olive oil. Plan a Mediterranean type diet using more fiber and starches, especially whole grain, raw fruits, and vegetables. A plant-based diet may be useful. The DASH diet contains 3 to 4 grams sodium with good sources of potassium, calcium, and magnesium. Dairy products provide calcium, magnesium, and potassium. Monitor blood glucose level. Carbohydrate restriction has been shown to improve dyslipidemias associated with syndrome X more than a low-fat diet. Encourage soy proteins as a meat substitute several times a week. Soy protein may help with weight reduction and dyslipidemia. Ensure adequate intake of folate, vitamin B6, B12, vitamin C, and E, preferably from food. Dark chocolate in small amount regularly may help lower blood pressure, improve cholesterol, and help with insulin sensitivity. Spread out the energy load by eating smaller meals. Common drugs used and potential side effects. To lower lipids, a statin should be used initially unless contraindicated. Statin decrease biomarkers of inflammation and oxidative stress in a dose-related manners. Atorvastatin 80 milligram compared with a 10 milligram dose is superior for decreasing oxidized LDL. Glucose lowering medication must be carefully prescribed and monitored. Metformin may be indicated. Blood pressure medications may be prescribed. Monitor for necessary restrictions of sodium and or higher need for potassium. NAC inhibitors or an angiotensin receptor blockers is usually the first medication. Medications that diminish insulin resistance and directly alter lipoproteins are necessary. Combination therapy is often required. If patients with syndrome X have elevated fibrinogen and other coagulation factors leading to prothrombotic stat, aspirin is used. Low-dose aspirin is not generally a problem, taken with a meal or light snack to prevent potential for GI bleeding. Antioxidant supplements are not recommended, but intake of antioxidant-rich foods should be suggested. Those far trials with alpha tocopherol have been disappointing. Further trials with gamma and alpha tocopherols are warranted. Include phytochemicals, antioxidant foods, and species such as turmeric, cumin, and cinnamon in the diet. Chromium bicarbonate enhance insulin action by lowering plasma membrane cholesterol. Coenzyme Q10 may have some merit, but further research is needed. High serum selenium concentrations have been associated with prevalence of high fibrinogen, LDL, triglyceride, and glycosidated high hemoglobin levels. Further research is needed to determine its role in the development or the progression of syndrome X. Other herbs and potential supplement shouldn't be used without discussing with physician. Nutrition education, counseling, care management. السلام عليكم، نعتذر عن المشكلة. حصلت مشكلة في برنامج زوم. Nutrition education, counseling, and care management. Widespread screening is recommended to slow the growth of this syndrome. Prevention should start in childhood with healthy nutrition, daily physical activity, and annual measurement of weight, height, and blood pressure, beginning at 3 years of age. Discuss the role of nutrition, for example, DASH or Mediterranean diet principles in managing this syndrome. Obesity is a major contributor to the problem. So weight loss, even 10 pounds, can help improve health status. A diet rich in antioxidants are beneficial. Finally, the 2005 dietary guidelines are consistent with lowering risk of syndrome X. Regular physical activity can help to lower elevated blood cholesterol level and blood pressure. Walking or an exercise that is pleasant for the individual is the one to select. Aerobic and strength training exercise are beneficial. Reduce sedentary activities include television and computer time. Smoking cessation measures may be needed. Offer guidance on how not to gain weight after quitting smoke. Patient education, foodborne illness. If home tube feeding is needed, teach appropriate sanitation and food handling procedure. COVID-19 and diabetes. COVID-19 infection in people with or without previously recognized diabetes increase the risk of the emergency states of hyperglycemia with ketones, diabetic ketoacidosis, and hyperosmolar hyperglycemic stat. Being acutely unwell with suspected or confirmed COVID-19 requires adjustment to standard approaches to diabetes management. Early in admission. Key difference with COVID-19. People with COVID-19 infection appear to have a greater risk of hyperglycemia with ketones, including People with type 2 diabetes risk even greater if on SGLT2 inhibitor. People with newly diagnosed diabetes. COVID-19 disease precipitate a typical presentation of diabetes emergency, for example, mixed diabetic ketoacidosis and hyperosmolar stat. Suggested action: check blood glucose in everybody on admission. Check ketones. Everybody with diabetes being admitted. Everybody with an admission glucose over 12 millimole. Stop SGLT2 inhibitors in all people admitted to hospital. And consider using 10 to 20% glucose where ketosis persists despite treatment in line with usual protocols. Severe illness on admission. Fluid requirements may differ in those with DKA and HS and evidence of lung leak or myocarditis. Suggested action: after restoring the circulating volume, the rate of fluid replacement regimen may need to be adjusted where evidence of lung leak or myocarditis. Contact the diabetes specialist team early. Early involvement of the critical care team. All inpatient area. Infusion pumps may not be available to manage hyperglycemia using intravenous insulin, as these are required elsewhere, for example, for sedation in ICU. Use alternative subcutaneous regimen to manage hyperglycemia and mild diabetic ketoacidosis. Contact the diabetes specialist team for support. ICU. Significant insulin resistance seen in people with type 2 diabetes in ICU setting. IV insulin protocols may need amending, people seen requiring up to 20 units per hour. Patients often nursed prone, so feeding may be accidentally interrupted. Paradoxical risk of hypoglycemia. COVID-19 infection in people with or without previously recognized diabetes increase the risk of the emergency stats of hyperglycemia. with ketones, diabetic ketoacidosis, and hyperosmolar hyperglycemic stats. Management of acute diabetes at the front door for emergency department and acute medical units. Patient assessment, for sure, we're gonna start with ABCD. Shortness of breath can also be due to metabolic acidosis, for example, diabetic ketoacidosis. Ensure all newly admitted patients are evaluated for diabetes. Glucose measurement in all patients and ketones check if known diabetes or blood glucose level above 12 millimole per liter. Stop SGLT2 inhibitors and metformin in all patients. Review safety of continuing AC inhibitors, non-steroidal and angiotensin release inhibitor. Blood glucose level advice, known or unknown diabetes. Glucose less than 4 millimole per liter, hypoglycemia, follow local guidance. If glucose more than 12 millimole per liter or known diabetes. Primary diagnosis to urgently consider. DKA defined as glucose more than 11 millimole per liter or history of diabetes. Blood ketones more than 3 millimole per liter or urine ketones more than or equal plus 2. pH less than 7.3 or bicarb less than 15. Note, glucose can be normal in SGLT2 inhibitor associated DKA and pregnancy associated DKA. Hyperosmolar hyperglycemic syndrome defined as glucose more than or equal 30 millimole per liter, serum osmolality 2 over sodium plus glucose plus urea more than 320 milliosmolar per kg and the pH more than 7.3. Follow local guidelines if either of above is confirmed and involved diabetes team as soon as possible, as changes to usual fluid replacement regimen may be necessary. Please note this, never stop basal insulin in person with known type 1 diabetes or DKA may result. Other urgent cause of hyperglycemia to consider. New presentation of diabetes type 1 or type 2, age, overweight, irrelevant for either. Sepsis, for example, COVID-19 or foot infection. Missed, delayed usual diabetes treatment, for example, insulin pen or personal insulin pump problem. Reflection of uncontrolled diabetes, inappropriate treatment regimen. If the patient has a recent hemoglobin A1C available, oral steroid use, persistently high glucose level may need treatment with subcutaneous or intravenous insulin. If an infusion pump is not available for IV insulin, then seek advice regarding an alternative subcutaneous regimen. In all cases, if unsure, please ask for advice from the diabetes team as early as possible or follow the local protocols. Blood ketone level advice. Blood ketones less than 0.6 millimole per deciliter is a safe level. Blood ketones between 1.5 to 2.9 millimole per liter increased the DKA risk if the patient PO or IV used. Consider rapid-acting insulin if glucose above 16 millimole per deciliter. 1 unit rapid-acting insulin typically expected to lower glucose by anywhere between 1 to 3 millimole per liter and recheck in 2 hours. Blood ketones 3 millimole per liter or greater than. Then check for the pH and bicarb, venous blood gas, DKA confirmed if high ketones are combined with blood glucose more than 11 millimole per deciliter, or there's a history of diabetes, and pH less than 7.3 or bicarbonate less than 15. Glucose can be less than 11 millimole per deciliter if patient are on SGLT2 inhibitor treatment, pregnant, or severe COVID-19 infection. Insulin advice. Always ask if your patient is on insulin. Always continue usual long-acting basal insulin. Patients who are very sick or not eating should have a variable rate intravenous insulin infusion with usual basal subcutaneous insulin continued alongside. If infusion pump isn't available for IV insulin, contact diabetes team or follow local protocols for an alternative subcutaneous regimen. Patients using wearable diabetes technology. If patients are unable to manage their personal insulin pump and no specialist advice is immediately available, Then start on subcutaneous basal bolus insulin regimen, then remove the pump and store it safely. If subcutaneous regimen required and not able to find out total daily insulin dose from pump, then the following could be safe. Calculate total daily insulin dose using 0.5 unit per kg. Give half the total dose as basal background insulin, half as bolus mealtime rapid-acting insulin. For example, 0.5 units when the patient weight is 60 kilograms, so the total daily insulin dose of 30 units. Give half the dose, which is 15 units as basal insulin and 15 units as bolus insulin, 5 units at each meal time. Ensure that pump is disconnected after subcutaneous basal insulin given. Continuous glucose monitors and freestyle labor device can be left on the patient, but conventional capillary glucose monitors will still be necessary. For imaging, when the patient needs to have CT or MRI, insulin pump, continuous glucose monitoring, and freestyle labor device need to be removed for magnetic scan. Footnotes: always need to exclude acute foot infection because it may be the source of sepsis or critical limb ischemia. Always ensure foot intact and protected. Take action on acute foot disease as per local diabetic food protocols. We're gonna stop here and have a break for 15 minutes, and I'm gonna put the slides when we're gonna start again. we're going to continue from here. Risk factors for hypoglycemia, medical issues, strict glycemic control, previous history of severe hypoglycemia, long duration of type 1 diabetes, duration of insulin therapy in type 2 diabetes, lipohypertrophy at injection site, impaired awareness of hypoglycemia, severe hepatic dysfunction, impaired renal function, including those patient requiring renal replacement therapy, sepsis, inadequate treatment of previous hypoglycemia, terminal illness, cognitive dysfunction, and dementia. Lifestyle issues, increased exercise relative to usual, irregular lifestyle, increasing age, early pregnancy, breastfeeding, no or inadequate blood glucose monitoring, reduced carbohydrate intake, absorption, food malabsorption, for example, gastroenteritis, celiac disease, bariatric surgery involving bowel resection, multivariable logistic regression analysis showed that age older than 70 years, cognitive dysfunction, and nephropathy were independently associated with hypoglycemia. Be aware that the following can also precipitate hypoglycemia: current use of medication with hypoglycemic agent, for example, warfarin, quinine, salicylate, partase, sulfonamides, monoamine oxidase inhibitors, non-steroidal anti-inflammatory drugs, propinicide, somatostatin analogs, and SSRI. Don't stop or withhold medication. Discuss with the medical team or pharmacist. Loss of counter-regulatory hormonal function, for example, in Addison's disease, growth hormone deficiency, hypothyroidism, and hypopituitarism. Potential causes of inpatient hypoglycemia. One of the most serious and common causes of inpatient hypoglycemia are insulin prescription errors include misreading poorly written prescriptions when U is used for units. For example, 4 units become 40 units. Confusing the insulin name with the dose. For example, Humalog mix 25 becoming Humalog 25 units. Confusing the insulin strength with the dose. For example, 100 unit dose indifferently prescribed. Transcription error. For example, where patient on animal insulin is inadvertently prescribed human insulin, or where handwriting is unclear. Inappropriately withdrawing insulin using a standard insulin syringe, 100 units per ml, from pre-filled insulin pens containing higher insulin concentration, for example, 200 units per milliliter or 300 units per milliliter. Confusion between the prescription of glucose and insulin infusion for hyperkalemia and glucose and insulin infusion to control blood glucose. For example, 10 units of insulin in 50 ml, 50% dextrose prescribed instead of 50 units in 50 ml normal saline. Medical issues: inappropriate use of stat or PRN, rapid short-acting insulin. Acute discontinuation of long-term corticosteroid therapy. Mobilization after illness. Recovery from acute illness and stress. Major amputation of a limb. Incorrect type of insulin or oral hypoglycemic. Therapy prescribed and administered. Inappropriately timed insulin or oral hypoglycemic therapy in relation to meal or enteral feed. Change of insulin injection site. IV insulin infusion with or without glucose infusion. inadequate mixing of intermediate acting or mixed insulin, regular insulin doses or oral hypoglycemia, therapy being given in hospital when these are not routinely taken at home, failure to monitor blood glucose adequately whilst on IV insulin infusion, carbohydrate intake issues, missed or delayed meals, less carbohydrate than normal, change of the timing of the biggest meal of the day, like the main meal at midday rather than evening, lack of access to usual between meal or before bed snacks, prolonged starvation time, for example, nil by mouth, vomiting, reduced appetite, and reduced carbohydrate intake, omitting glucose whilst on IV insulin infusion. Morbidity and mortality. Hypoglycemia can cause coma, hemiparesis, and seizures. If the hypoglycemia is prolonged, the neurological deficits may become permanent. Acute hypoglycemia impairs many aspects of cognitive function, particularly those involving planning and multitasking. The long-term effects of repeated exposure to severe hypoglycemia is less clear. The ACCRD study highlighted a potential risk of intensive glycemic control, recognized and unrecognized hypoglycemia was more common in the intensive group than in the standard group. In the intensive group, a small but statistically significant inverse relationship of uncertain clinical importance was identified between the number of hypoglycemic episodes and the risk of death among participants. Patients on insulin therapy remain in hospital for longer if they experience hypoglycemia, 7 days compared with 4 days. Patients on insulin therapy also had greater inpatient mortality if they experienced hypoglycemia compared to those who didn't, 12.9% and 11% respectively. The inpatient mortality rate increased to 24.9% in those with hypoglycemia defined as less than 2.2 millimole per deciliter. It was examined data from 4,368 admission episodes for people with diabetes, of which one-third were on regular insulin therapy. Patients experiencing inpatient hypoglycemia experienced a 66% increased risk of death within 1 year and spent 2.8 days longer in hospital compared to those not experiencing hypoglycemia. Increased mortality rates were reported for inpatients on insulin therapy who experienced hypoglycemia, blood glucose less than 2.8 millimole per liter compared to those with no hypoglycemia, 20.3% versus 4.5%. However, only 41 to 51% of these participants had diabetes, and subgroup analysis of those with diabetes would have been useful. Impaired awareness of hypoglycemia. Impaired awareness of hypoglycemia is an acquired syndrome associated with insulin treatment. Impaired awareness of hypoglycemia results in the warning symptoms of hypoglycemia become diminished in intensity, altered in nature, or lost altogether. This increases the vulnerability of affected individuals of progression to severe hypoglycemia. The prevalence of impaired awareness of hypoglycemia increases with duration of diabetes and is much more common in type 1 than in type 2 diabetes. Managing hypos in hospitals. People experiencing hypoglycemia requires quick-acting carbohydrate to return their blood glucose levels to the normal range. The quick-acting carbohydrate should be followed up by giving long-acting carbohydrate either as a snack or as part of planned meal. All patients experiencing hypoglycemia should be treated without delay. Where it's safe to do so, A blood glucose measurement should be taken to confirm hypoglycemia. If measurement is difficult, for example, in a patient undergoing a seizure, then treatment shouldn't be delayed. After acute treatment, consideration should be given to whether أعتذر منكم يا أخوان، لكن الزوم فيه مشكلة، يعني كل شوية بيطلعني، فأعتذر منكم. كده الصوت مسموع؟ Managing hypoglycemia in hospitals. People experiencing hypoglycemia requires quick-acting carbohydrate to return their blood glucose levels to the normal range. The quick-acting carbohydrate should be followed up by giving long-acting carbohydrates, either as a snack or as part of planned meal. All patients experiencing hypoglycemia should be treated without delay. Where it's safe to do so, a blood glucose measurement should be taken to confirm hypoglycemia. If measurement is difficult, for example, in patient undergoing seizure, then treatment shouldn't be delayed. After acute treatment, consideration should be given to whether the hypoglycemia is likely to be prolonged as a result of long-acting insulin or sulfonylurea therapy. These patients may require a continuous infusion of glucose to maintain blood glucose level. Normal blood glucose level in person without diabetes are 3.5 to 7 millimole per liter. To avoid potential hypoglycemia, Diabetes United Kingdom recommends a practical policy of make 4 millimole per liter is the lowest acceptable blood glucose level in people with diabetes. Regular blood glucose monitoring enables detection of asymptomatic biochemical hypoglycemia. Evidence for treatment options. There is limited evidence regarding the quantity of quick-acting carbohydrate required to successfully treat an episode of hypoglycemia. The initial quantities chosen were the result of expert consensus subsequently backed up with glucose clamp study. Fendazole compared 15 gram versus 20 gram and found that 32 to 63% of episodes resolved after one treatment with 15 gram carbohydrates compared with 55 to 89 of episodes with 20 gram carbohydrate. Larson used continuous glucose monitoring to monitor 125 adult patients with type 1 diabetes over 6 days. They defined adequate treatment as ingesting 10 to 20 grams of quick-acting carbohydrate. They reported that 30% of hypoglycemic episodes were under-treated, less than 10 gram carbohydrate consumed, and 38% were over-treated for more than 20 gram carbohydrate consumed. Participants who were under-treated had a 57% chance of remaining hypoglycemic at the repeated test. This compares with 30% for those adequately treated and 26% for those over-treated. This reinforces the suggestion that treatment of hypoglycemia with less than 10 grams of quick-acting carbohydrate is likely to be inadequate. Overtreatment of hypoglycemic episode is often seen both in the community and hospital. 73% of hypoglycemic episodes were overtreated. More than 20 grams of rapid-acting carbohydrate consumed in adults with type 1 diabetes. The mean amount of carbohydrate used to treat was 32 grams. Chocolate is no longer recommended for the treatment of hypoglycemia. Chocolate contains quick-acting carbohydrate and fat. The addition of fat has been shown to slow the absorption of quick-acting carbohydrate. Orange juice, which contain fructose, remaining a popular treatment for hypoglycemia. The results of 2 studies using a modified glucose clamp technique have suggested that orange juice may not be the most effective treatment in adults with type 1 diabetes. But those reported that almost double the amount of orange juice was required to reduce a similar increment compared with the glucose tablets. The total sugar content of any fruit juice varies according to the ripeness of the fruit, the season it is picked, and the addition of any sugar when packaged. A more recent study showed that fructose in the form of a fruit bar was less effective than sucrose in successfully treating hypoglycemia in children with type 1 diabetes. The pre in the bar may have slowed down the absorption of fructose, reducing its efficacy as a treatment of hypoglycemia. By contrast, a recent real-world study of children with type 1 diabetes attending a diabetes camp found orange juice to be as effective as other treatments. Several studies have examined the time interval between treatment and retesting to confirm resolutions of hypoglycemia. All are supportive of a minimum interval of at least 10 minutes before retesting to ensure resolution of hypoglycemia. Slama concludes that repeating carbohydrate intake every 5 to 10 minutes wouldn't allow adequate time for the treatment to take effect, thus leading to overtreatment. Benedictus reported that when hypoglycemia was treated with 20 grams of carbohydrate, 55% were adequately treated after a 5-minute wait, compared with 89% after a 10 minutes wait. Evidence of parenteral treatment options. Intramuscular glucagon and intravenous glucose in varying concentration are the main treatment options. A randomized trial of people attending the emergency department with hypoglycemia found glucagon almost as effective as intravenous dextrose, with no difference in adverse effects, for example, vomiting, although recovery of blood glucose levels was slower with glucagon. Faster recovery of blood glucose levels using intravenous glucose compared with intramuscular glucagon was shown in two subsequent studies into the pre-hospital treatment of hypoglycemia. Repeated administration of glucagon is not advised. Only 1% of people responded to a second injection of glucagon who hadn't responded to the first injection. Glucagon will be less effective in those people with depleted glycogen reverse, such as those with impaired hepatic function. In summary, glucagon is effective and can be a useful treatment option, especially outside the hospital setting when intravenous access may not be available. However, it can only be used once with a slower recovery and higher treatment failure rate, making intravenous glucose the preferred option. The increment in blood glucose after administration of 50% glucose varies widely between individuals with hypoglycemia. The mean increment in participants with diabetes was 9.8 millimole per liter, with a large standard deviation of 4.4 millimole per liter. There's a positive evidence comparing 10% or 20% dextrose with 50% dextrose. Moore and Woolard administered 5 grams of either 10% or 50% glucose at 1 minute interval to people with hypoglycemia until recovery of consciousness level had occurred. Participants were selected on the basis of confusion or impaired consciousness level sufficient to make treatment with oral carbohydrate inadvisable. Using 10% glucose resulted in lower post-treatment glucose level, 6.2 versus 9.4 millimole per liter. 10 grams of carbohydrate delivered as 10% dextrose in the pre-hospital setting, resulted in adequate treatment of hypoglycemia for most patients with only 18% requiring an additional 100 milliliter of 10% dextrose. The risk of extravasation injury with any hypertonic solution may make 10% dextrose safer than 50% glucose. Glucose 10% preparations are considerably less hypertonic than the 50% preparation and therefore less destructive to the venous endothelium. A Japanese study using rabbit ears found that increasing the duration of infusion decreased the tolerance of peripheral veins to solutions of increased osmolality. 10% glucose has an osmolality of 5.6 per liter compared with 2,522 per liter for the 50% dextrose. For these reasons, 10% or 20% glucose solution are preferred. Alterations to treatment regimens with the aim of reducing hypoglycemia. Therapeutic inertia can make healthcare professionals slow to respond to hypoglycemic events or to proactively reduce insulin dose in those identified as at risk of hypoglycemia. Matthew found that only 44% of patients had their insulin doses reduced by a suitable amount following an episode of hypoglycemia. There is evidence that implementation of hypoglycemia reduction bundle in hospital environment can reduce rates of hypoglycemia. Treatment of hypoglycemia in patients who are conscious and able to swallow 15 to 20 grams of fast-acting carbohydrate is the treatment of choice. Subsequent treatment algorithms discuss treatment options for those unable to consume oral carbohydrate. Adults who have poor glycemic control may start to experience symptoms of hypoglycemia above 4 millimole per liter. There is no evidence that the threshold for cognitive dysfunction are pressed upwards. Therefore, the only reason for treatment is symptomatic relief. So adults who are experiencing hypoglycemia symptom but have a blood glucose level greater than 4 millimole per liter, treat with a small carbohydrate snack only, for example, one medium banana, a slice of bread, or normal meal if due. All adults with a blood glucose level less than 4 millimole per liter with or without symptoms of hypoglycemia should be treated as outlined in this guideline. Dose adjustment for normal eating is a course for people with type 1 diabetes designed to teach patients how to adjust their insulin dose according to their carbohydrate consumption, carbohydrate counting. Dose adjustment for normal eating principles suggest that hypoglycemia is treated at the level of 3.5 millimole per liter and that long-acting carbohydrate is not always required. However, on hospitalized patients with the Joint British Diabetes Society for Inpatient Care, suggest a target blood glucose of 6 to 10 millimole per liter. Therefore, this guidance recommends that in the hospital environment, a blood glucose of less than 4 millimole per liter is treated as hypoglycemia in all patients with diabetes. Continuous subcutaneous insulin infusion or insulin pumps administer rapid-acting insulin on a continuous basis via subcutaneous cannula. Continuous subcutaneous insulin infusion is used by some people with type 1 diabetes, and some patients are taught that long-acting carbohydrates may not always be required. However, if hypoglycemia reoccurs, then long-acting carbohydrate must be given after initial treatment, and the patient referred to the diabetes inpatient specialist team. The conclusion: most patients with diabetes are admitted for reasons not directly related to their diabetes. Adequate management of their diabetes while inpatient, including timely recognition, treatment, and prevention of hypoglycemia, will help reduce morbidity and prevent length in patient stay. These guidelines are intended to guide the assessment and management of a hospital inpatient with diabetes. Each patient should be individually assessed and management altered where necessary. You may want to agree local guidance for the self-management of hypoglycemia in conjunction with certain other medical conditions. For example, renal impairment, congestive cardiac failure. Many people with diabetes carry their own supplies of oral carbohydrate and should be supported to self-manage when capable and appropriate. This decision should be recorded in their hospital care plan. Patients capable of self-care should alert nursing staff that an episode of hypoglycemia has occurred so that their management plan can be altered if necessary. Many episodes of hypoglycemia are avoidable, so every preventable measure should be taken. Easily accessible, quick, and long-acting carbohydrate must be available in your clinical area, and all staff should be aware of its location. Managing hospitalized diabetic adults. Adults who are conscious, oriented, and able to swallow. Give 15 to 20 gram quick-acting carbohydrate of the patient's choice where possible. Some examples are 5 to 7 dextrose tablet or 4 to 5 glucotabs, 1 bottle 60 milliliter gluco juice, 150 to 20 milliliter pure fruit juice, for example, orange. 3 to 4 heaped teaspoons of sugar dissolved in water. Patient following a low potassium diet due to chronic kidney disease shouldn't use orange juice to treat hypoglycemia due to its potassium content. Sugar dissolved in water is not an effective treatment for patient taking acropose, as it prevents the breakdown of sucrose to glucose. It should also only be considered if no other treatment options are readily available. Repeat capillary blood glucose measurement 10 to 15 minutes later. If it's still less than 4 millimole per liter, repeat step 1, no more than 3 treatments in total. If blood glucose remains less than 4 millimole per liter after 30 to 45 minutes or 3 cycles, contact a doctor and consider 1 milligram of glucagon by IM may be less effective in patient prescribed sulfonylurea therapy. 150 to 200 milliliter of 10% glucose over 15 minutes, for example, 600 to 800 milliliter per hour. Care should be taken with infusion pump settings if larger volume bags are used to ensure that whole bag is not indifferently administered. Volume should be determined by clinical circumstance. Once blood glucose is above 4 millimole per liter and the patient has recovered, give a long-acting carbohydrate of the patient's choice where possible, taking into consideration any specific dietary requirement. Examples include 2 biscuits, 1 slice of bread or toast, 200 to 300 milliliter glass of milk, not soya. Normal meal, if due, must contain carbohydrate. Patient given glucagon require a larger portions of long-acting carbohydrate to replenish glycogen storage, double the suggested amount above, although nausea associated with glucagon injection may be an issue. Insulin injection, if it's due, however, the insulin regimen review may be required. Patient who self-manage their insulin pump may not need a long-acting carbohydrate, but should take initial treatment as outlined and adjusted their pump setting appropriately. Many patients will have a locally devised hypoglycemia protocol that should be checked to ensure that it remains appropriate for use in the inpatient setting. If the hypoglycemia was due to sulfonylurea or long-acting insulin therapy, then be aware that the risk of hypoglycemia may persist for up to 24 to 36 hours following the last dose, especially if there is renal impairment. Document events in patient's note. Ensure a regular capillary blood glucose monitor is continued for at least 24 to 48 hours. Ask the patient to continue with this at home if they are to be discharged. Give hypoglycemia education or refer to local diabetes inpatient team. Adults who are conscious but confused, disoriented, unable to cooperate, or aggressive but are able to swallow. If the patient is capable and cooperative, follow previously mentioned guidelines. If the patient is not capable or uncooperative but can swallow, give either 1.5 to 2 tubes, 40% glucose gel, squeezed into the mouth between the teeth and gums. Or if this is ineffective, give glucagon 1 milligram IM, may be less effective in patient prescribed sulfonylurea therapy. Repeat capillary blood glucose levels after 10 to 15 minutes. If it's still less than 4 millimole per liter, repeat steps 1 and 2. No more than 3 treatments in total, and only give IM glucagon once. If a blood glucose level remains less than 4 millimole per liter, after 30 to 45 minutes, contact a doctor. Consider intravenous glucose, 150 to 200 milliliter of 10% glucose over 50 minutes, delivered at an infusion rate of 600 to 800 milliliter per hour. Care should be taken with infusion pump setting if larger volume bags are used to ensure that the whole bag is not inadvertently administered. Volume should be determined by clinical circumstances. Once blood glucose is above 4 millimole per liter and the patient has recovered, give a long-acting carbohydrate of the patient's choice where patient possible, taking into consideration any specific dietary requirements. Example includes 2 biscuits, 1 slice of bread and toast, 200 to 300 milliliter glass of milk, not soya, and normal meal, if due, must contain carbohydrate. Patients given glucagon require a large portion of long-acting carbohydrate to replenish glycogen store. Patients who self-manage their insulin pumps may not need a long-acting carbohydrate, but should take initial treatment, continue their pump, and assess for the cause of the episode. Patients who self-manage their insulin pumps may not need a long-acting carbohydrate, but should take initial treatment as outlined and adjust their pump setting appropriately. Many patients will have a local device, the hypoglycemia protocols, that should be checked to ensure that it remains appropriate for use in the inpatient setting. If the hypoglycemia was due to sulfonylurea or long-acting insulin therapy, then be aware that the risk of hypoglycemia may persist for up to 24 to 36 hours following the last dose, especially if there is concurrent renal impairment. Document events in patient's note. Ensure regular capillary blood glucose monitoring is continued for at least 24 to 48 hours. Ask the patient to continue this at home if they are to be discharged. Give hypoglycemia education or refer to diabetes inpatient team. Adults who are unconscious or having seizure or are very aggressive, check the airway and give oxygen. Breathing the circulation. The disability include the GCS and blood glucose exposure, including temperature. If the patient has an insulin infusion in situ, stop immediately. Request immediate assistance from medical staff, fast bleep a doctor. The following three options are all appropriate. Local agreement should be sought. If IV access available, give 75 to 100 milliliter of 20% glucose over 15 minutes. For example, 300 to 400 milliliter per hour. 100 milliliter preparation of 20% glucose is now available that will deliver the required amount after being run through a standard giving set. If an infusion pump is available, use this, but if not readily available, the infusion shouldn't be delayed. Repeat capillary blood glucose measurement 10 minutes later. If it's still less than 4 millimole per liter, repeat. If IV access available, give 150 to 200 milliliter of 10% glucose over 15 minutes. If the infusion pump is available, use this, but if not readily available, then infusion shouldn't be delayed. Care should be taken if larger volume bags are used to ensure that the whole infusion is not indifferently administered. Repeat capillary blood glucose measurement 10 minutes later. If it is still less than 4 millimole per liter, then repeat. If no IV access is available, then give 1 milligram glucagon IM. Glucagon 1 milligram IM may be less effective in patients prescribed sulfonylurea therapy and may take up to 15 minutes to take effect. Glucagon mobilizes glycogen from the liver and will be less effective in those who are chronically malnourished, including those who have had a prolonged period of starvation or have severe liver disease. In this situation, IV glucose is the preferred option. Once the blood glucose is greater than 4 millimole per liter and the patient has recovered, give a long-acting carbohydrate of the patient's choice where possible, taking into consideration any specific dietary requirements. Some examples are two biscuits on slice of bread and toast, 200 to 300 ml of glass of milk, not soy milk, and normal meal if it is the time of the main meal. And it must be contain carbohydrate. Patient given glucagon require a larger portion of long-acting carbohydrate to replenish glycogen store. And the patient who self-managed their insulin pump may not need a long-acting carbohydrate. If the patient was on IV insulin, continues to check blood glucose every 15 minutes until above 3.5 millimole per liter, then restart IV insulin. After review of dose regimen to try and prevent hypoglycemia recurrence. Consider concurrent IV 10% glucose infusion at 100 milliliter per hour or stepping down the insulin increments on the variable scale of if appropriate. If the hypoglycemia was due to sulfonylurea or long-acting insulin therapy, then be aware that the risk of hypoglycemia may persist for up to 36 hours following the last dose, especially if there is renal impairment. Document events in patient notes. Ensure regular capillary blood glucose monitoring is continued for at least 24 to 48 hours. Ask the patient to continue this at home if they are to be discharged. Give hypoglycemia education or refer to diabetes inpatient team. We're gonna stop here. and we're gonna take a prayer break, and we will be back. I'm gonna put it on the slide. Thank you. بسم الله الرحمن الرحيم. Adults who are nil by mouth. If the patient has a variable rate, intravenous insulin infusion, adjust as per prescribed regimen and seek medical advice. Most variable rate intravenous insulin infusions should be restarted once blood glucose is above 4 millimole per liter, although an infusion rate adjustment may be indicated. Option 1 and 2, intravenous glucose, are both appropriate treatment options. Again, local agreement should be sought. Once blood glucose is greater than 4 millimole per liter and the patient has recovered, consider intravenous infusion of 10% glucose at a rate of 100 milliliter per hour until patient is no longer nil by mouth or has been reviewed by a doctor. If the hypoglycemia was due to sulfonylurea or long-acting insulin therapy, then be aware that the risk of hypoglycemia may persist for up to 36 hours following the last dose, especially if there is concurrent renal impairment. Document event in patients. Note, ensure regular capillary blood glucose monitoring is continued for at least 24 to 48 hours. Ask the patient to continue this at home if they are to be discharged. Give hypoglycemia education or refer to DISA. Adult requiring enteral parenteral feeding. Patient requiring total parenteral nutrition should be referred to a dietitian, nutrition team, and diabetes team for individual assessment. Risk factors for hypoglycemia. Blocked displaced tube, change in feeding regimen, enteral feed discontinued, total parenteral nutrition or IV glucose discontinued, diabetes medication administered at an inappropriate time to feed, changes in medication that cause hyperglycemia. For example, steroid therapy reduced, stopped, feed intolerance, vomiting, deterioration in renal function, severe hepatic dysfunction. Treatment to be administered via feed tube. Don't administer these treatment via total parenteral nutrition line in patient receiving TPN. Treatment should be administered orally or intravenously as appropriate. Give 15 to 20 gram quick-acting carbohydrate if the patient choice were possible. Some examples are 1.5 to 2 tubes, 40% glucose gel, 1 bottle, 60 milliliter loco juice, 150 to 200 milliliter orange juice, and 110 to 140 fruit juice, not fruity sip, to give 15 to 20 gram carbohydrate. Restart feed to rapidly deliver 15 to 20 gram carbohydrate. All treatment should be followed by 40 to 50 milliliter water of the feeding tube to prevent tube blockage. Repeat capillary blood glucose measurement 10 to 20 to 15 minutes later. If it's still less than 4 millimole per liter, repeat step 1, no more than 3 treatments in total. If blood glucose remain less than 4 millimole per liter after 30 to 45 minutes or 3 cycles, consider one 50 to 20 milliliter of 10% glucose administered intravenously over 15 minutes. For example, 600 to 800 milliliter per hour. Care should be taken with infusion pump setting if larger volume bags are used to ensure that the whole bag is not inadvertently administered. Once blood glucose is above 4 millimole per liter and the patient has recovered, restart feed. If bolus feeding, give additional bolus feed. Read the nutritional information and calculate amount required to give 20 grams of carbohydrate. 10% IV glucose at 100 milliliter per hour. Volume should be determined by clinical circumstance. Don't insulin injection if due, however, insulin regimen review may be required. If the hypoglycemia was due to sulfonylurea or long-acting insulin therapy, then be aware that the risk of hypoglycemia may persist for up to 24 to 56 hours following the last dose, especially if there is concurrent renal impairment. Document event in patient's notes. Ensure regular capillary blood glucose monitoring is continued for at least 24 to 48 hours. Ask the patient to continue this at home if they are to be discharged. Give hypoglycemia education or refer to dietitian. Ensure patient has been referred to a dietitian for individualized hypoglycemia treatment advice. When hypoglycemia has been successfully treated, complete an audit form and send it to the dietitian. Some trusts have utilized pre-printed stickers in patient's note, both for documentation and audit purpose. Consider completing an incident form if appropriate. Identify the risk factor or cause resulting in hypoglycemia. Take measures to avoid hypoglycemia in the future. The dietitian or inpatient diabetes team can be contacted to discuss this. Unless the cause is easily identifiable and both the nursing staff and patient care confident that steps can be taken to avoid future events, a medical or dietitian review should be considered. If the hypoglycemia event was severe or recurrent, or if the patient voiced concern, then a review is indicated. Please don't finish insulin injection or start variable rate intravenous insulin infusion to stabilize blood glucose. If unsure of subsequent diabetes treatment, discuss with the diabetes team. For example, it may be safe to administer a mealtime bolus dose of rapid-acting insulin if the patient is declining food and has taken their usual basal insulin. Medical team or dietitian, if referred to, consider reducing the dose of insulin prior to the time of previous hypoglycemia event. This is to prevent further hypoglycemia episodes occurring. Please don't treat isolated spikes of hypoglycemia with stat dose of rapid-acting insulin. Instead, maintain regular capillary blood glucose monitoring and adjust normal insulin regimen only if a particular pattern emerges. Gestational diabetes. The definition and background. Gestational diabetes involves glucose intolerance with first onset or recognition during pregnancy. It affects 14 to 25% of all pregnancies, increasing over the past decade. Pregnancy itself is a metabolic stress test. During the first half of pregnancy, transfer of maternal glucose to the fetus occurs. During the second half of pregnancy, placental hormones outweigh glucose transfer and insulin requirement typically double. Placenta functions as a nutrient sensor, altering placental transport according to the maternal supply of nutrients. Placental transports are regulated by hormones such as insulin. Insulin resistance occurs when gestational hormones such as human placental lactogen interferes with insulin action. The accelerated fetal growth in women with diabetes is characterized by increased activity of placental and glucose transporters. Cell signaling for insulin changes in gestational diabetes. Women with diabetes or gestational diabetes may need 1 to 2 times more insulin than other pregnant women. All pregnant women should be assessed for risk of gestational diabetes at the first prenatal visit. Most women are screened between 24 and 28 weeks of gestation. One or more of the following factors identifies women at risk for gestational diabetes: ethnicity, Hispanic Americans, African Americans, Asian, Pacific Islander, American Indian, family history of diabetes in a first-degree relative, parents or siblings, gestational diabetes or presence of a birth defect in previous pregnancy, history of pregnancy-induced hypertension, urinary tract infection, or hydramnios extra-amniotic fluid. History of abnormal glucose tolerance, older maternal age, 25-year-old, pre-pregnancy overweight or obesity, BMI 29, previous birth of a large baby, more than 9 pounds, previous stillbirth or spontaneous miscarriage. Hyperglycemia in pregnancy poses many complications and risks for the infant, such as macrosomia, neural tube defects, hypocalcemia, hypomagnesemia, and hyperbilirubinemia, birth trauma, prematurity, or neonatal hypoglycemia. Fasting glucose level shouldn't exceed 105 milligram per deciliter. Excellent blood glucose control with diet, and when necessary, insulin will result in improved prenatal outcome. Hemoglobin A1C testing is not useful in gestational diabetes. Women with a prior history of gestational diabetes and obesity are at a significant high risk of developing MACE. There is a higher risk of hypertension, preeclampsia, UTI, cesarean section, and future diabetes. About half of women who have gestational diabetes will proceed to have type 2 diabetes later, especially women who are hypertensive. Nutrition recommendations should be used on through nutrition assessment, monitoring blood glucose level, urine ketones, appetite, and weight gain guides, the individualized nutrition prescription and meal plan. Adjustment should be made to the meal plan throughout pregnancy to ensure desired outcome. In women who have had bariatric surgery, close nutritional evaluation will be needed. Deficiencies in iron, vitamin A, vitamin B12, vitamin K, folate, and calcium can result in both maternal anemia and fetal complications, such as congenital abnormalities, offspring of women with gestational diabetes are at increased risk for respiratory distress, macrosomia, jaundice, hypoglycemia, hyperinsulinemia, birth trauma, and developmental problems. Development of METS in late adolescence and young adulthood is related to maternal glycemia in the third trimester, maternal obesity, neonatal macrosomia, and childhood obesity. Although treatment of mild gestational doesn't significantly reduce the frequency of stillbirth, parental death, or several neonatal complications, it does reduce the risk of fetal overgrowth, shoulder dystocia, cesarean delivery, and hypertensive disorders. Family planning, early screening for fetal abnormalities, compliance, glycemic and blood pressure control during pregnancies, and improved neonatal care can make a difference. After birth, rapid adoption is necessary for infant to be able to maintain independent glucose homeostasis. This is compromised in infants who are small for gestational age, premature, or large for gestational age. Obesity, insulin resistance, and abnormal lipid metabolism consequences for future generations. For women who are offered treatment for mild gestational diabetes in addition to routine obstetric care, additional charges are incurred, but fewer babies experiences serious perinatal complication or death. Nutritional intervention for gestational diabetes saves thousands of dollars per case. All women with gestational diabetes should receive nutritional counseling by an RD. And initiated within 1 week of diagnosis and with a minimum of 3 nutrition visits, result in decreased hospital admission and insulin use, improve likelihood of normal fetal and placental growth, and reduce risk of prenatal complication, especially when diagnosed and treated early. Intervention. Prevent complications, perinatal morbidity, and mortality by normalizing the levels of glycemia and other metabolites like lipids and amino acids to the level of non-diabetic pregnant individual. Optimize growth and development of the fetus. Desirable maternal weight gain will vary according to the pre-pregnancy and current weight. Optimal weight gain is generally as follows. First trimester, 0.5 to 1 kg. Second and third trimester, 0.2 to 0.5 kg per week. Prevent weight loss. Obese women should control weight gain carefully. Excessive weight gain may be a form of the metis and offspring, prevent infections and unexpected outcomes. Fetal glucose exposure and consequent fetal insulin secretion is normally tightly regulated by glucose delivery from the mother during pregnancy. The risk of spontaneous preterm birth increases with increasing levels of pregnancy glycemia. Control blood pressure. Avoid incident of starvation ketosis where glucose is needed, and diabetic acidosis where insulin and potassium are needed. By regular preprandial and postprandial CPG, ketosis is harmful to the baby. Use insulin when necessary, based on measures of maternal glycemia with or without assessment of fetal growth. Insulin therapy is recommended when nutrition intervention fails to maintain fasting whole blood glucose at desired levels. Prevent hypoglycemic episodes, urinary tract infection, and candidiasis. Promote healthy lifestyle changes for the mother that will last long after delivery. Women with gestational diabetes should be encouraged to breastfeed. Physical activity, especially after meals, can help to maintain blood glucose control. Contraindications to exercise may include pregnancy-induced hypertension, intrauterine growth retardation, preterm labor or history of preterm labor, incompetent cervical circulage, and persistent second or third trimester bleeding. Food and nutrition. Use a carbohydrate-controlled meal plan with adequate intake to keep weight gain appropriate while preventing glycemic shifts or ketonuria. Manage for age and weight goals. Provide adequate energy and nutrients to meet the need. Maternal blood glucose goals that have been established. A typical diet may include 30 to 35 kilocalories per kg, 20% protein, 40 to 45 of carbohydrate, and 35 to 40 of fat. Select a carbohydrate from whole grain, one fruit portion or one milk portion at a time. Limit juice, sweets, and desserts. Sufficient carbohydrate intake is needed, 175 grams at minimum. Many women with gestational diabetes underrate out of fear of needing insulin. Interval weight loss may indicate presence of fasting ketones. Insulin may be needed. While a low glycemic index diet may be beneficial for some outcome for both mother and child, results are inclusive at this time. For obese women, BMI 30, a caloric limit 25 kilocalories per kg, actual weight per day has been shown to reduce hyperglycemia and plasma triglycerides with no increase in ketonuria. For many women, this translates to an energy intake around 1,700 to 1,800 kilocalories. Artificial sweeteners may be used, but not Saccharin. Maintain an adequate intake of polyunsaturated fats. Keep saturated fats to 10% of total fat or less. Most women require 3 meals and 4 to 5 snacks. Snacks are eaten at least 2 to 3 hours between feeding and should contain carbohydrate. Smaller, more frequent meals and snacks will be beneficial because of insulin resistance. Work closely with a dietitian to establish the best pattern according to typical blood glucose level. A snack before bedtime may be needed. DASH diet principles may be helpful if blood pressure is elevated. Include regular use of antioxidant food and species such as cinnamon. Ensure intake of parenteral vitamin mineral supplements, especially containing 600 gram folic acid, 30 to 60 milligram iron, vitamin C, and adequate calcium. Include adequate chromium intake from diet as in yeast breads. Tube feeding may be useful in patients who cannot be fed orally or with hyperemesis. Carbohydrate control products are not necessarily required. Monitor closely. After delivery, a review of glucose tolerance and postpartum nutrition is suggested at 6 to 12 weeks. Common drugs used and potential side effects. Investigators found no substantial maternal or neonatal outcome difference between use of glyburide or metformin compared with the use of insulin in gestational diabetes. Insulin may be required to control blood glucose if diet and exercise don't help. Care for physician and self-monitoring is important. The insulin lispro is associated with fewer hypoglycemic events. Use prenatal vitamin mineral supplements such as prescribed. Avoid large dose of vitamin C, which may show false positive urinary glucose level. More than 200 milligram per deciliter is not needed. Low-dose estrogen, progesterone, oral contraceptive may be used after gestational diabetes if no medical contraindication exists. However, medications that worsen insulin resistance, for example, glucocorticoid, nicotinic acid, should be avoided if possible. Herbs and supplements. In general, pregnant women shouldn't take any herbs and potential products. They should discuss concurrent or previous use with their physician. Supplements of 1,25 dihydroxy vitamins D3 may influence glucose metabolism in gestational diabetes by increasing insulin sensitivity. More research is needed on postpartum requirements. Only limited evidence exists to support prenatal omega-3 supplementation. Use caution for an unbalanced high DHA intake during the first 2 trimesters of pregnancy. That is DHA without additional amino acid supplementation. Conflicting results have been found for specific nutrients. Zinc and selenium seem to be protective, whereas chromium doesn't. More research is needed for micronutrient recommendation to be made. Nutrition, education, counseling, care management. The RD should monitor and evaluate blood glucose, weight, food intake, physical activity, and pharmacological therapy if indicated in women with gestational diabetes at each visit. And then result in improved maternal and neonatal outcomes. Communicates the importance of meal spacing, timing, adequacy, and constancy. Patients shouldn't skip meals. Instructions on what to eat and what to avoid will be important. Carrying a snack at all times is helpful. For example, fruit, peanut butter, crackers. Follow current evidence-based guidelines. Regular aerobic exercise, such as walking, is beneficial. Exercise after meals may help to control blood sugar, but don't exercise until short of birth. Upper body exercises are also beneficial. Avoid exercise while lying on back, as this decreases blood flow when the weight of the fetus presses on the main artery. Avoid exercise that increase the risk of falling, and encourage breastfeeding. Babies born to women who have gestational diabetes may have low levels of lipids, such as arachidonic acid and deoxynic acid. Further studies are needed. Encourage family planning to ensure optimal glucose regulation for all subsequent pregnancy. Women with a history of gestational diabetes are more likely to have recurrent diabetes if they are older, heavier, and wait longer between pregnancies, for example, 3 versus 2 years in many cases. Recurrence of gestational diabetes is common, especially among non-Caucasian population. Any degree of abnormal glucose homeostasis during pregnancy independently predict an increased risk of glucose intolerance and cardiovascular disease postpartum. Elevated fasting blood glucose or oral glucose tolerance test 2 hours and oral glucose tolerance glucose A1C are strong and constant predictors of subsequent type 2 diabetes. Long-term lifestyle modification. Maintenance of normal body weight and physical activity should be discussed. Discuss the potential impact of gestational diabetes on offspring. who are at increased risk of obesity, glucose intolerance, and diabetes in late adolescence or adulthood. Patient education, foodborne illness. If home tube feeding is needed, teach appropriate sanitation and food handling procedures. Preeclampsia and pregnancy-induced hypertension. Preeclampsia is defined as the association of pregnancy-induced hypertension and proteinuria of 300 milligram in 24 hours or more after 20 weeks gestation. It's more common in primary gravida and in patients with multiple gestation, type 1 diabetes, teenage mothers, family history of pregnancy-induced hypertension, age over 40 years, or underlying vascular or renal disease. It affects 2 to 8% of pregnancies and is a severe complication which may lead to fatal morbidity and mortality. Risks for the baby include poor growth and prematurity. Preeclampsia can lead to problems in the liver, kidneys, brain, and the clotting system. Maternal morbidity includes placental abruption, HELLP syndrome, which is hemolysis, elevated liver enzyme, low platelet, or eclampsia. Treatment consists of ending the pregnancy. Early sonogram is recommended. Many women will have to have total bed rest. Maternal morbidity includes placental abruption, HELLP syndrome, and severe preeclampsia that develops at 34 weeks of gestation is associated with high prenatal mortality and morbidity. Women who are 37 weeks pregnant are induced immediately. Criteria for mild preeclampsia. Hypertension as defined at 140/90 to 159/109. Proteinuria more than 300 milligram in 24 hours. Mild edema with weight gain more than 20 pounds per week or 6 pounds per month. Urine output more than 500 milliliter in 24 hours. Signs and symptoms. Increased blood pressure, proteinuria, facial edema, pretibial pitting edema, irritability, nervousness, headache, altered states of consciousness, epigastric pain, oliguria, criteria for severe preeclampsia. Blood pressure more than 160/110 on 2 occasions with patient on bed rest. Systolic blood pressure raised more than 60 over baseline. Diastolic blood pressure increase of 30 over baseline. Proteinuria more than 5 grams in 24 hours or 3 to or 4 on a urine dipstick. Massive edema and oliguria less than 400 milliliters per every 24 hours. And also includes pulmonary edema, severe headache, visual changes, right upper quadrant pain, elevated liver enzyme, and thrombocytopenia, in addition to the symptoms listed for mild preeclampsia. An eclampsia seizure occurs. Eclamptic seizures and symptoms of the HELLP syndrome occur. In severe cases, there may also be hepatic rupture, pulmonary edema, acute renal failure, placental abruption, elevated creatinine, intrauterine growth restriction, cerebral hemorrhage, cortical blindness, and retinal detachment. Maternal mortality rate is 8 to 36%. Because plasma homocysteine is often increased, sufficient intake of folic acid, vitamin B12 and B6 are recommended. Studies have also shown the effectiveness of magnesium in eclampsia and preeclampsia. Intervention: reduce maternal and neonatal mortality and morbidity in pregnant patients with diabetes and chronic hypertension. Blood pressure target goal of 110 to 129 over 65 to 79 are suggested. Avoid lower blood pressure because fetal growth may be impaired. Lesion edema when present. Correct any underlying malnutrition or micronutrient deficiency. Monitor any sudden weight gain, 1 kilogram per week, that are unexplained by food intake. Prevent, if possible, chronic hypertension and metastasis after delivery. Common drugs used and potential side effects. The only interventions shown to prevent preeclampsia are antiplatelet agents, primarily low-dose aspirin, calcium supplementation, and magnesium sulfate for eclamptic seizures. Avoid excessive magnesium from supplements if this medication is being used. Corticosteroids for lung maturity may be necessary during pregnancy. Typical diuretic and cardiac drugs are not used. AC inhibitors and ARBs are contraindicated. Calcium pump inhibitor are often a first-line choice. Herbs and supplements. Herbs and potential supplements shouldn't be used in pregnancies. Evening primorase has been suggested for this condition. Coenzyme Q10 and alpha tocopherol and are potent antioxidant. Nutrient education and counseling care management. Rest is essential during this time. Biofeedback, yoga, meditation, and other forms of stress reduction are often beneficial. Meal skipping should be avoided at all costs. Discuss adequate sources of calcium from the diet, especially if dairy products are not tolerated or preferred. Good source of potassium and magnesium include nut, fruit, and vegetables. The DASH diet is an excellent diet to continue even after pregnancy. Potential complication of diabetes. Hyperglycemia. Symptoms include polyphagia, polydipsia, polyuria, dehydration, weight loss, weakness, muscle wasting, recurrent or persistent infections, hypovolemia, ketonemia, glycosuria, blurred or changed vision, fatigue, muscle cramp, and dry mouth. Blood glucose, 250 milligram per deciliter should be evaluated. Monitor blood or urine ketones to check for diabetic ketoacidosis. 3 forms of hyperglycemia may be noted in the hospitalized patient. Someone with a history of diagnosed diabetes, previously unrecognized diabetes, hospital-related fasting blood glucose of 126 milligram per deciliter or random blood glucose of 200 milligram per deciliter that reverts to normal after discharge. DKA or non-ketotic hyperosmolar stat. The stress of illness, trauma, or surgery frequently aggravate glycemic control and may precipitate DKA or non-ketotic hyperosmolar stat. A vomiting illness combined by ketosis may indicate DKA. A life-threatening condition that requires immediate medical care to prevent complication and death. Cerebral edema can occur. Early consultation with an endocrinologist is needed. Hypoglycemia symptoms, shakiness, confusion, diplopia, irritability, hunger, weakness, headache, and rapid and shallow breathing. Numbness of mouth, lips, and tongues. Pulse normal or abnormal, convulsions, lack of coordination, and dizziness. Staggering gait, pallor, slurred speech, tingling, diaphoresis, nausea, sweating, tremor, and nightmares. Treat when blood glucose level is 70 milligram per deciliter with 15 grams of liquid or fat-free source of glucose or carbohydrate. Wait 15 minutes and retest. Then treat with another 15 grams of carbohydrate if still 70 milligram. Evaluate blood glucose after 1 hour. Continue to monitor until next meal. Adding protein to carbohydrate doesn't affect the glycemic response and doesn't prevent subsequent hypoglycemia, but adding fat may retard and then prolong the acute glycemic response. In rare severe hypoglycemia, when the individual requires the assistance of other person and cannot be treated with oral carbohydrate, emergency glucagon kits may be used. Down phenomenon. The Down phenomenon is the end results of a combination of natural body changes that occur during the sleep cycle. Between 3 a.m. and 8 a.m., the body naturally starts to increase the amount of counter-regulatory hormones. growth hormone, cortisol, and catecholamines, which work against insulin action to drop sugar. These cause a blood sugar levels to raise in the morning. Somoggy effect, rebound hyperglycemia lead to high blood sugar levels in the morning, precedes by an episode of asymptomatic hypoglycemia. When blood sugar drops too low in the middle of the night, the body counters by releasing hormones to raise the sugar levels. Too much insulin earlier or not enough of a bedtime snack may be the problem. We're gonna stop here and we'll have a break, and it will be the last break. After that, we will finish our lecture.
Acute illness or infection, the risk of DKA is higher during this time, test blood glucose, drink adequate amount of fluid, ingest carbohydrate, 50-gram carbohydrate every 3 to 4 hours if blood glucose level are low, and adjust medication to keep glucose in desired range and to prevent starvation ketosis. Marked hyperglycemia requires temporary adjustment of the treatment program, and if accompanied by ketosis, frequent interaction with the diabetes care team, hospitalization may be needed. In pediatric case, cerebral edema may occur. Referral to a pediatric endocrinologist is important. Vaccines. Annually provide an influenza vaccine to all diabetic patients 6 months of age. Provide at least one lifetime pneumococcal vaccine for adults with diabetes. Persons who have diabetes tend to be at higher than normal risk for bacterial forms of pneumonia. Critical illness. In critically ill patients, blood glucose level should be kept as close to 110 milligram per deciliter, equals 6.1 millimole per liter, as possible, and generally 180 milligram per deciliter, 10 mole per liter intravenous. Venous insulin is usually needed. Scheduled prandial insulin dose should be given in relation to meal and should be adjusted according to point of care glucose level. Traditional sliding scale insulin regimen may be ineffective and are not useful. Potential complication of diabetes, intermediate. Children with type 1 diabetes, children's growth and development may be impaired with diabetes. Adequate protein and energy must be provided. Children may be picky eaters. Blood glucose goals are less strict. Target range for normal blood glucose is 90 to 130 milligram per deciliter before eating for 13 to 19 years old, 90 to 180 milligram per deciliter for 6 to 12 years old, and 100 to 180 milligram per deciliter for 12 months till 5 years old, may be altered according to the healthcare provider's evaluations. Near normalization of a blood glucose level is slightly attainable in children and adolescents after the honeymoon remission period. The A1C goals also vary in children. Most children under 6 or 7 years of age have hypoglycemic unawareness. Young children lack the cognitive capacity to recognize and respond to hypoglycemic symptoms. Children with diabetes differ from adults in many ways, including insulin sensitivity related to sexual maturity, physical growth, ability to provide self-care, vulnerability to hypoglycemia, differing from family dynamics, developmental stages, and physiological difference. Work with the family and school to plan for emergencies such as low or high blood glucose level. Children with type 2 diabetes. Distinction between type 1 and type 2 diabetes in children can be difficult because of autoantigen, and ketosis may be present in substantial number of patients. Children with type 2 diabetes are usually overweight or obese and present with glycosuria with or without ketonuria, absent or mild polyuria and polydipsia, and little or no weight loss. Up to 33% have ketonuria at diagnosis. Some may have ketoacidosis without any associated stress, illness, or infection. Preconception: all women with diabetes and childbearing potential should be educated about the need for good glucose control before pregnancy, the need for family planning, and need for early treatment for diabetic retinopathy, nephropathy, and neuropathy, and cardiovascular disease. A1C levels should be normal or as close to normal as possible, 1% above the upper limits of normal in an individual before consumption is attempted. Pregnancy and diabetes. Infant mortality rates are approximately twice as high for babies born to women with uncontrolled diabetes compared with babies born to women without diabetes. To reduce the risk of fatal malformations and maternal or fatal complications, pregnant women and women planning to become pregnant require excellent blood glucose control. These women need to be seen frequently by multidisciplinary team. Specialized laboratory and diagnostic tests may be needed. Women with diabetes must be trained in self-monitoring of blood glucose. Nutrition recommendations for women with pre-existing diabetes must be based on through assessment. Monitoring blood glucose level, blood or urine ketones, a peptide, and weight gain is needed to develop an individualized nutrition prescription and to make adjustment to the meal plan. Plasma glucose should be maintained at 65 to 100 milligram per deciliter before meals and in fasting, 110 and 135 milligram per deciliter 1 hour after meals, and 120 milligram per deciliter 2 hours after meals. Use an extra 300 kilocalorie daily during the second and third trimester, 1 gram per kg per day, or an additional 25 gram per deciliter of protein, 175 gram per deciliter of carbohydrate, and 600 gram folic acid. Added iron and calcium may be required. Lactation. Extra protein, calcium, and folic acid will be needed. Monitoring of blood glucose is recommended, but hypoglycemia should be avoided. Breastfeeding lowers blood glucose and may require women to eat a carbohydrate-containing snack either before or during breastfeeding. Extra 330 to 40 kilocalorie meets the needs of most lactation mothers. Unexplained weight loss should be viewed as a symptoms of a problem. Diabetes is an important health condition for the aging population. At least 20% of patients over the age of 65 years have diabetes. These patients tend to have higher rates of premature death, functional disability, and coexisting illness, such as hypertension, heart disease, stroke, than those with diabetes, without diabetes. New-onset diabetes in adults over the age of 50 may signal underlying pancreatic cancer, which should be investigated. Strict diets in long-term care are not warranted and may lead to dehydration and malnutrition. Specialized diabetic diets are not required, and a balanced diet with consistent timing of carbohydrates is to be recommended. Modify medication rather than diet as needed. Lower hypertension gradually. Important, implement the DASH diet whenever possible. A multivitamin mineral supplement may be beneficial for this population. Potential complication of diabetes, the chronic retinopathy. Retinopathy from diabetes accounts for 12,000 to 24,000 cases of blindness each year. Optimal glycemic and blood pressure control can substantially reduce the risk of progression of diabetic retinopathy. In the presence of proliferative diabetic retinopathy or severe non-proliferative diabetic retinopathy, vigorous aerobic or resistance exercise may be contraindicated because of the risk of triggering vitreous hemorrhage or retinal detachment. Pregnancy and type 1 diabetes may aggravate retinopathy. Laser photocoagulation surgery can minimize the risk. Microalbuminuria and nephropathy. Early signs of nephropathy include hyperfiltration, renal hypertrophy, and microalbuminuria, loss of 30 to 300 grams per milligram creatinine in the urine. Protein losses at a rate of 300 grams per milligram creatinine may indicate advancement toward chronic kidney disease. To reduce the risk and or slow the progression of nephropathy, optimize glucose and blood pressure control. Nephropathy is preceded by microalbuminuria for several years. Onset of end-stage renal disease is about 5 years after onset of microalbuminuria. For diabetic nephropathy, liberalized carbohydrate intake and control insulin level accordingly. Control protein intake will slow down progression of nephropathy. Adult needs 0.8 to 1 gram protein per kg daily. Protein restriction
is of benefit in slowing the progression of albuminuria, glomerular filtration rate decline, and occurrence of end-stage renal disease. Protein restriction should be considered in patients whose nephropathy seems to be progressing despite optimal glucose and blood pressure control and use of angiotensin converting enzyme inhibitors or angiotensin receptor blocker. Intensive diabetes management with the goal of achieving near normal glycemia has been shown to delay the onset of microalbuminuria. Refer to a physician experienced in the care of diabetic renal disease when the estimated glomerular filtration rate has fallen to 60 ml per minute, or if difficulties occur in the management of hypertension or hyperkalemia. ACE inhibitors are almost always prescribed to decrease progression. End-stage renal disease. Diabetes is the leading cause of chronic kidney disease, especially among Blacks, Mexican American, and Native American. Diabetic nephropathy occurs in 20 to 40% of patients with diabetes and is the single leading cause of end-stage renal disease. Creatinine and glomerular filtration rate should be assessed annually in this population. Microalbuminuria 30 to 299 milligram in 24 hours and macroalbuminuria 300 milligram in 24 hours should be carefully monitored. While physical activity can acutely increase urinary protein excretion, there is no evidence that vigorous exercise increased the rate of progression of diabetic kidney disease. Autonomic neuropathy. About 70% of persons who have diabetes have some degree of neuropathy, including impaired sensation in the hands and feet, slow digestion, or carpal tunnel syndrome. Autonomic neuropathy can decrease cardiac responsiveness to exercise, causing postural hypotension, impaired thermoregulation, impaired skin blood flow and sweating, impaired night vision, impaired thirst, risk of dehydration, and gastroparesis with unpredictable food delivery. Neuropathy may be delayed with careful blood glucose management. Weight loss may be beneficial for obese person. Decreased pain sensation in the extremities may increase risk of skin breakdown and infection and joint destruction. It may be best to encourage non-weight-bearing activities such as swimming, bicycling, or arm exercise. Diabetic autonomic neuropathy is associated with recurrent genitourinary tract disturbance or bladder or sexual dysfunction, amputation. Lower extremity amputations are painful and disabling. Prevention is desirable. Amputation and foot ulcers are the most common consequences of diabetic neuropathy and the major cause of morbidity and disability in people with diabetes. Major clinical manifestations of cardiac neuropathy in diabetes include resting tachycardia, exercise intolerance, orthostatic hypotension, constipation, gastroparesis, erectile dysfunction, pseudomotor dysfunction, impaired neurovascular function, brittle diabetes, and hypoglycemic autonomic failure. Evaluate cardiac status before starting an exercise program. GI neuropathy. GI disturbance, esophageal enteropathy, gastroparesis, constipation, diarrhea, and fecal incontinence are common. And any section of the GI tract may be affected. Gastroparesis should be suspected in individual with erratic glucose control, macrovascular coronary artery disease, and arterial vascular disease. Cardiovascular disease is a major cause of mortality and also a major contributor to morbidity in diabetes. Type 2 diabetes is an independent risk factor for macrovascular disease. Other risk factors include insulin resistance, hyperglycemia, hypertension, dyslipidemia, and smoking. Smoking is related to the premature development of microvascular complications of diabetes and may have a role in the development of type 2 diabetes. Advise all patients not to smoke. Include smoking cessation as a routine component of care. Dyslipidemia, lifestyle modification focusing on the reduction of saturated fat and cholesterol intake, weight loss, if indicated, and increased physical activity has been shown to improve the lipid profile in patients with diabetes. Guidelines promote low density lipoprotein cholesterol level of 100 milligram per deciliter as optimal for all patients and lowering of triglyceride levels when 150 milligram per deciliter. Statin may be helpful. Elevated high density lipoprotein to levels 50 milligram per deciliter. If high density lipoprotein is 50 milligram per deciliter and the LDL is between 100 and 129 milligram per deciliter, a fibric acid derivative or niacin might be used. Niacin raised HDL but can significantly increase the blood glucose at high dose. Use aspirin therapy, 75 to 162 milligram per deciliter, as a secondary prevention strategy in those with diabetes with a history of cardiovascular disease. Tailor nutrition interventions according to each patient age, type of diabetes, pharmacological treatment, lipid levels, and other medical conditions. focus on the reduction of saturated fat, cholesterol, and trans fat intake. Monitoring of homocysteine levels and related actions should be taken. Adequate insulin therapy often returns lipid to normal in type 1 diabetes. Elevated levels in type 2 diabetes require strict management. Limit saturated fat to 7 to 10% of total calories. The rate of heart disease is about 2 to 4 times higher in adults who have diabetes. It is the leading cause of diabetes-related death. Since people with diabetes tend to have high triglyceride and low HDL levels, omega-3 fatty acid from DHA and EPA, fish and marine oils can help. Hypertension. Over 70% of adults with diabetes also have hypertension. Control of hypertension in diabetes has been linked to a reduction in the progression of both microvascular and macrovascular disease. In type 1 diabetes, hypertension is often the result of underlying nephropathy, whereas in type 2 diabetes, it may be present as part of the metabolic syndrome. Patient with systolic blood pressure 140 or diastolic blood pressure 90 should receive drug therapy in addition to lifestyle and behavioral therapy. Blood pressure should be measured at every routine diabetes visit. Patient with diabetes should be treated to reach a systolic blood pressure 130 and diastolic blood pressure 80. In patients with type 1 diabetes with hypertension and any degree of albuminuria, ACE inhibitors have been shown to delay the progression of nephropathy. With type 2 diabetes, hypertension, and microalbuminuria, ACE inhibitors and ARBs have been shown to delay the progression to macroalbuminuria. Modest weight loss is helpful, prevent hypokalemia, which can blunt insulin release. Control glucose, limit smoking, and add exercise. Use the DASH diet because it increases intake of calcium, magnesium, and potassium while lowering excess weight. Hypertension in pregnancy. Pregnancy-induced hypertension is 2 to 4 times more common in women with type 1 diabetes than the general population. Screen for microalbuminuria has a strong predictor of preeclampsia. In pregnant patients with diabetes and chronic hypertension, blood pressure target goals are 110 to 129 over 65 to 79. Avoid lower blood pressure because fetal growth may be impaired. ACE inhibitors and ARBs are contraindicated during pregnancy. Stroke risk is 2 to 4 times higher among persons with diabetes, and high blood pressure should be carefully controlled. Catabolic illness, such as HIV infection, AIDS, or cancer, changes body compartments with increased extracellular fluid and shrink age of body fat and cell mass. Monitor unexplained weight loss carefully, especially 10% or more of usual weight. Standard tube feeding are usually well tolerated in person with diabetes. 50% carbohydrate or lower. Monitor fluid status, weight, plasma glucose, and electrolytes and acid-base balance. Overfeeding is to be avoided. Start with 25 to 35 kilocalories per kg of body weight. Protein needs maybe 1 gram per kg up to 1.5 gram per kg in stressed individual, and pressure ulcer may require a higher level of protein and calories than normal for healing. Addition of insulin may be needed. Oral glucose lowering medications need to be adjusted adequate control to achieve adequate control of glycemia. Diabetic gastroparesis. Definition and background. Gastroparesis occur in approximately 50% of all cases of diabetes with delayed gastric emptying and the absence of mechanical obstruction. Diabetic gastroparesis is the result of ongoing damage to the nerves that are responsible for peristalsis and normal motility. Food digests abnormally. Slow peristalsis is diminished so that it's difficult to match insulin action to digestion and absorption of the meals. If food stays in the stomach too long, infection is possible. Also, the food can harden into a solid lump. These fissures may cause pain, nausea, and blockage in the digestive tract. Hypoglycemia can occur if insulin is working and if food remains in the stomach too long. Later, insulin action is diminished and food finally digests, causing hyperglycemia. Problems occur more often in type 1 than in type 2. Strict glycemic control is key. A gastrostomy is rarely indicated, but a jejunostomy may be helpful in maintaining nutrition. Prokinetic agents are the best treatment options. Gastric electrical stimulation may be used to send out free flow energy and bolus to the stomach to decrease nausea and vomiting. Intervention. Correct the fluctuating blood glucose level through careful food and insulin management, frequent blood glucose checks, and monitoring records. For nausea and vomiting, restore volume and hydration and provide antiemetic generously. Relieve symptoms, pain, diarrhea, constipation, and maintain adequate nutrition stats. Differentiate from ketoacidosis, which has similar symptoms of nausea and vomiting. prevent infection or preserve formation from accumulation of indigestible solids. Monitor intake carefully. Blood glucose fluctuations are common, include 200 to 240 gram carbohydrate daily spread throughout the day. Use 2 to 3 carbohydrate serving per meal. Be constant from day to day. Soft to liquid diet may be useful to prevent delay in gastric emptying. 6 small meals may be better tolerated than large meal. Use a low-fat diet to improve digestion and to improve stomach emptying. Stay sitting after meals. Decrease overall fiber intake from meals or supplements. Oranges, broccoli, green beans, berries, figs, and fresh apples may be difficult to digest. For dry mouth, add extra fluid and moisten foods with both or allowed sauces or gravies. If nausea occur, cold foods and low odor choices may be better tolerated. In severe problems, a percutaneous gingiostomy tube feeding may be indicated. It can be used temporarily if needed to correct malnutrition. Common drug used and potential side effects. Prokinetics such as metoclopramide may be given 30 minutes before meals to increase gastric contraction and to relax pyloric sphincter. Dry mouth, sleepiness, diarrhea, or nausea can be side effects. Metazole is a nasal spray form of this medication. Metoclopramide prophylaxis to reduce gastric volume before elective surgery is unnecessary unless the patient has a prolonged history of poor blood glucose control. Rapid-acting insulin should be injected with or after meals. Use SIMBG to monitor delay absorption and glucose changes. Insulin Lispro is quite effective because it starts working shortly after injection. To control blood glucose, it may be necessary to take insulin more often, to take insulin after eating instead before, and to check blood glucose often after eating. If a liquid diet is used, more insulin may be needed. Insulin pumps may be beneficial because insulin delivery rate can be programmed to the patient's individual needs. Because there is a reciprocal relationship between gastric emptying and ambient glucose concentrations, neurodiabetic therapies that accelerate the rate of gastric emptying may be a beneficial tool. Antiemetic may be used for vomiting. Monitor for specific side effects. Zofran may cause constipation or headache. Erythromycin improves stomach emptying by increasing the contraction that moves food through the stomach. Side effects are nausea, vomiting, diarrhea, and abdominal cramp. Dramamine is an antihistamine that helps prevent nausea and vomiting, slight to moderate drowsiness, and thickening of bronchial secretion may occur. Mutolium domperidone is used to manage the upper GI problem. Side effects may include headache. Herbs supplements shouldn't be used without discussing with physician. Discuss delayed digestion and absorption of food. discuss role of diet in maintaining weight and control discomfort, emphasize nutrient-dense food if intake has been poor, blenderized foods or smoothies may be well tolerated. Usual formations may occur after eating orange, coconuts, green beans, apples, figs, potato skins, Brussels sprouts, broccoli, succulent corn, and other high fiber food. Discuss insulin management as appropriate. Include information about CPG and meal spacing. Advise the doctor if blood glucose level are 200 milligram per deciliter. Patient education. If home tube feeding is needed, teach appropriate sanitation and food handling procedure. Diabetic ketoacidosis. Ketones in the urine means that the body is burning fat to get energy because glucose is not available. The lack of insulin leads to gluconeogenesis in the liver. Then glucose spills into the urine and cause an osmotic diuresis with dehydration. Free fatty acids are released from the adipose tissue and converted into acidic ketones, acetoacetate, and hydroxybutyrate by the liver. Large amount of ketones in the serum and urine can be dangerous. Diabetic ketoacidosis is a classic metabolic acidosis, a medical emergency that accounts for more than 100,000 hospital admissions yearly in the United States. A patient with a low serum potassium level should be assumed to have a potentially life-threatening crisis. Causes of DKA: not getting enough insulin from missed injection, alkaline reverse depleted by too little insulin, flu or cold, fever, pregnancy, stress, trauma, myocardial infarction, infection. It's the leading cause, urinary tract infection and pneumonia. The triad of uncontrolled hyperglycemia, metabolic acidosis, and increased total body ketones concentration characterize DKA. These metabolic derangements result from the combination of absolute or relative insulin deficiencies and increased levels of the counter-regulatory hormones of glucagon, catecholamine, cortisol, and growth hormones. DKA is seen primarily in patients with type 1 diabetes. A few type 1 diabetes patients present with DKA on initial diagnosis. In children, DKA is a leading cause of hospitalization and is a cause of cerebral edema, which may lead to death if untreated. DKA can also occur in type 2 diabetes, usually from urinary tract infection, trauma, stress, pregnancy, surgery, or myocardial infarction. Inflammatory process may play a role. Both DKA and its treatment procedures, varying degrees of immunological stress. All individuals with DKA should be tested for hyperthyroidism. Use of standardized written guidelines have merit. Intervention. Correct the high blood glucose level by giving more insulin. Frequent blood glucose and ketone monitoring is necessary. Note that if urine ketones behind serum ketones because it takes time to the empty bladder where they have accumulated and been stored. Replace fluid and electrolyte lost through excessive urination and vomiting. Promotes returns to wellness after poor health or for several days. Evaluate precipitating factors such as surgery, trauma, UTI, pneumonia, or influenza. Monitor frequently to prevent recurrence of DKA. Prevent complications such as shock, arterial thrombosis, renal failure, or cerebral edema. Young children are especially vulnerable and may slip into a coma for chronically high fasting glucose level. Adjust evening, intermediate, or long-acting insulin dose or timing. Diagnostic criteria for diabetic ketoacidosis and hyperosmolar hyperglycemic. This figure shows the different type of diabetic ketoacidosis. And for the mild case, plasma glucose is more than 250. And the arterial pH is between 7.25 to 7.3. And the serum bicarb is 15 to 18. Urine ketones is positive, serum ketones also positive. Effective serum osmolality is variable, and the altered mental status in the mild case is alert. But in the moderate case, the pH is between 7 to 7.24, and the serum bicarb between 10 to 15, and the mental status alert but a little drowsy. In the severe case, the pH less than 7, and the serum bicarb less than 10, and the mental status is stupor and maybe coma, and the hyperosmolar hyperglycemic, the glucose in the plasma is more than 600, and the pH is more than 7.30, and the bicarb is more than 15, and the urine ketones will be small, and the serum ketones also small. The effective serum osmolality is more than 320, and the mental status is stupor or coma. Food and nutrition. If patient is comatose, intravenous insulin, electrolytes, and fluid are used. A nasogastric tube may be placed to prevent aspiration during feeding. If patient is alert and oriented, offer plenty of fluids orally. As treatment progresses, a 5% glucose solution is usually given as glucosuria and hyperglycemia subside. If glucosuria and hyperglycemia don't decrease, try tea and salty both. Later, fruit juice and liquids high in potassium may be given. Resolution of DKA leads to the ability to tolerate oral nutrition and fluid, normalization of blood acidity, pH 7.3, and absence of ketones in blood 1 millimole per liter. Once this has been achieved, insulin may be switched to the usual regimen. Common drugs used and potential side effects. Insulin fluids are usually given intravenously to decrease blood glucose by 50 to 75 milligram per deciliter per hour. Guidelines may be recommended a bolus initial large dose of insulin of 0.1 unit of insulin per kg of body weight if potassium level is higher than 3.3. Regular and glycerin insulin are equally effective during the acute treatment of DKA. A basal bolus regimen with galagreen and glycerin is safer than MPH and regular insulin after the resolution of DKA. Dextrose insulin is given once plasma glucose decreased to avoid accidental hypoglycemia. Potassium, phosphate, and magnesium level may be low. Bicarbonate therapy is needed only rarely. Intravenous antibiotic therapy will be needed where there is sepsis. Atypical antipsychotic, thiazide, diuretic, and corticosteroids can lead to DKA if the patient is not carefully monitored. Herbs and potential supplements shouldn't be used without discussing that with the physician. And the nutrition education, counseling, care management, explain demands for more insulin during illness and infection. Use of a diabetes record may be useful if episodes of high blood glucose are frequent. Never exercise when there are ketones present, because every episode of DKA implies breakdown in clinical communication. Appropriate diabetes education should be reinforced. Education of patient and their social environment to promote frequent testing, especially during sick days, and to lower their glucose levels, as well as to recognize the early symptoms of hyperglycemia and DKA is of paramount importance in preventing the development of severe DKA. When strict control through insulin is administered, weight gain is common. Insulin admission and reduction, which are eating disorder symptoms unique to diabetes mellitus, are associated with the increased risk of DKA. Attention to the disorder is important in overall treatment planning and management. The biggest risk of insulin pump therapy is DKA, since no long-acting insulin is used. Any interruption to insulin delivery or pump malfunctioning can cause DKA. To prevent this reaction, monitor blood glucose regularly. Insulin pump users should also need to check often to see that the insulin is still following through the tube. Patient education: if home tube feeding is needed, teach appropriate sanitation and food handling procedure. Hyperosmolar hyperglycemic status. I'm gonna stop here. Thank you so much for your listening. I'm gonna leave it now for discussion. If anyone have a question, he can ask me on the chat. So this is the end of the day.